and in this session I'm going to talk about cyst of the maxillofacial region. By definition, a cyst is a pathological cavity or a sac within hard or soft tissue that may contain fluid, semi-fluid or gas, and not always lined by epithelium. It may be lined by epithelium, fibrous tissue or occasionally even neoplastic tissue. It will always have a definitive connective tissue wall. Now let's move on to the pathogenesis of cyst formation. There are two phases of cyst formation. One is cyst initiation and the other is cyst enlargement. Now, stimulus for cyst initiation is unknown except for inflammatory odontogenic cyst, wherein infection is the predisposing factor. Some studies have also been conducted which shows that cyst and odontogenic tumors arises from epithelial rest of series, epithelial rest of malaces, reduced enamel epithelium of the crown, and even from the tooth bud itself, that is the dental lamina, dental papilla or dental sac. After cyst initiation, cyst formation takes place. Now this formation can either be because of proliferation of the epithelial lining or fluid accumulation in the cystic cavity or bone resorption. Now once formation has started, eventually enlargement takes place. Now enlargement could be increase in the volume of the content, increase in the surface area of the sac, that is by epithelial proliferation, resorption of the surrounding bone and displacement of the soft tissue. Now this entire procedure is best explained by mural growth theory put forward by Marx, which state that after the initiation or the stimulus, cells start to proliferate. As the cell starts to proliferate, the peripheral cells grow, the central cells are deprived of nutrition and blood supply, because of which they undergo necrosis. And all the necrotic content and debris start to accumulate in the center, which causes hypertonicity of the lumen. There is eventually transudation of the fluid from outside to the inside of the cystic cavity, eventually resulting in increased hydrostatic pressure and eventual enlargement of the cyst. Let's move on to the classification of cyst. WHO has classified cyst of the maxillofacial region into three broad categories: cyst of the jaw, cyst associated with the maxillary antrum, and cyst of the soft tissue of mouth, face and neck. Cyst of the jaw is further divided into epithelial and non-epithelial cyst. Non-epithelial cysts, for example, are solitary bone cyst and aneurysmal cyst. Epithelial cysts are further divided into developmental and inflammatory. Inflammatory, as I mentioned earlier, radicular cyst, residual cyst. Development could further be divided into odontogenic and non-odontogenic. In odontogenic, we have developmental cyst or dentigerous cyst, follicular cyst, eruption cyst, lateral periodontal cyst, gingival cyst of infant and newborn, etc. And non-odontogenic cyst involve nasopalatine duct cyst, nasolabial cyst, median palatal cyst. Cyst associated with maxillary antrum could be benign mucosal cyst or surgically ciliated cyst of the maxilla. Cyst of the soft tissue of the face, neck and mouth could be dermoid or epidermoid cyst, brachial cleft cyst, thyroglossal cyst, cystic hygroma, cyst of the salivary glands, and etc. So today in this session, we would see the clinical and radiographic features of few of the hard and soft tissue cysts of the maxillofacial region. We begin with the first one, that is primordial cyst. It is nothing but odontogenic epithelial developmental cyst. Now these cysts arise in a place where a tooth should have been present, but instead of that a cyst developed. Thus it derived from the dental lamina most commonly. It accounts for around 5 to 10% of the odontogenic cysts seen in the maxillofacial region, and it has a male predilection and seen more commonly in second, third and fourth decade of life. It is seen in the mandible more commonly, that too in the posterior part of the mandible, more commonly in the angle region. And clinically, these cysts could either be small or large. Most of the time they are asymptomatic. Since they expand through the medullary cavity, the clinical bone expansion is seen very late or by chance on a radiograph. There will always be a tooth missing from the normal series of radiograph. Radiographically, you would see either a unilocular radiolucency with well-defined sclerotic border, or you could have a scalloped sclerotic border giving it a multilocular appearance. It will try to displace the adjacent teeth, deviate it, It will also cause root resorption of the adjacent teeth if not treated. When you aspirate the cystic content, you will find a thick granular yellowish material. And if you send it for histopathological examination, the lining will be lined by a thin wall of irregular keratinized stratified squamous epithelium. The treatment is surgical enucleation with a regular follow-up. Now, since the cystic lining is very thin, there are chances of recurrence. That's the reason why a regular follow-up is must for these cases. So the tendency of recurrence could be because of thin cystic lining. They also have small satellite cyst in their lining which can regrow. And the cystic lining have a regrowth potential, proliferative potential. The next is dentigerous or follicular cyst. It is also odontogenic epithelial cyst. Now, as the name suggests, it is because of the proliferation of the dental follicle that occur associated with either impacted or unerupted or supernumerary tooth. So now this proliferation of dental follicle could arise because of either accumulation of fluid in the enamel organ or in the reduced enamel epithelium. Accumulation of fluids take place. Now, how will you differentiate a dentigerous cyst with an enlarged follicle? It is said that if the follicular width or the size of the follicle is more than 3 to 4 millimeter, then you should always suspect it as a follicular cyst. Now, it accounts for around 20% of the odontogenic cyst, more commonly seen in the male in first, second and third decade of life. The mandible is more commonly affected. Now, the number of teeth that is associated or affected by this is mandibular third molar region is more affected, followed by maxillary canine, then maxillary third molar, mandibular, second premolar and then supernumerary teeth. If you see, these are actually descending order of impacted tooth that are seen in the maxillofacial region. Now, clinically, this cyst have a capacity to expand. Okay, it can produce more facial bony expansion, resulting in facial asymmetry. So there will be an obvious facial asymmetry. It causes cortical plate expansion. Since it causes cortical plate expansion, when you palpate, an eggshell crackling sound can be elevated. Normally it is painless and hard swelling, but if it gets secondarily infected, then it becomes painful. Then it will create a problem. It might have discharge in the oral cavity. Then radiographically, you will see either a unilocular radiolucency or a multilocular radiolucency associated with impacted tooth. Radiographically, it will have three distinct configurations: circumferential type, lateral type, coronal type. Circumferential, as the name suggests, it will circumscribe the tooth as a whole. Lateral, the cyst will be on the lateral aspect of the impacted tooth attached to the tooth at cemento-enamel junction. Or the cyst could enclose the crown of the tooth only and get attached to the cemento-enamel junction. And it is also seen that these cystic lesions may displace the impacted tooth to varying degree. Like as you can see in the OPG, the impacted third molar is pushed towards the inferior border or angle of the mandible. It also causes root resorption, displacement of the adjacent teeth. Now when you aspirate, the cystic content is clear yellowish fluid with presence of cholesterol crystals. If it is infected, you will have a purulent material. Now when you send the lining for pathological examination, you will see reduced enamel epithelium, 2 to 3 layer of a non-keratinized cuboidal cell attached to the tooth at the cemento-enamel junction. Now the treatment of this cyst is, if the cyst is small, enucleation is sufficient. But if the cyst is large and involving a number of root apices, or if it is present in a younger age group, in that case you'll offer a marsupialization, and later on once the cyst size decreases, then you can offer an enucleation. Now these terms that I'm using, enucleation and marsupialization, I will describe them in detail in the next lecture. Let's move on to the third cyst, that is developmental lateral periodontal cyst. It is also odontogenic epithelial origin. It basically arises from the dental lamina, and it is very rare, more commonly seen in adult, more commonly affect the mandible, that too in the mandibular cuspid bicuspid region, followed by third molar and then the anterior region of the maxilla. Now you will classically see a small gingival swelling either at the attached gingiva or interdental papilla. Now this small painless nodule is seen on the lateral aspect of the root surface. And keep in mind that the teeth associated with it is normally vital. Whereas if there is periodontal abscess or a periodontal cyst, then the tooth is non-vital. But this is developmental lateral periodontal cyst wherein the tooth is vital. Then on radiograph, you will see either a round or ovoid or a pear-shaped radiolucency with well-sclerotic border. Okay, the lamina dura of the tooth associated with it is destroyed. Now this cyst are small in size, not more than 1 centimeter, and they basically lie from the cervical to region and between the cervical region and the root apex. It causes displacement of the root. Then when you aspirate it, a clear serous fluid can be aspirated. And when you send it for histological examination, you will see a well-keratinized stratified squamous epithelium. Treatment for this is enucleation. Let's move on to the another cyst, that is botryoid odontogenic cyst. Now this is nothing but a variant of lateral periodontal cyst. It occurs within the mandible in the cuspid premolar region and it appears as a polycystic lesion on the radiograph. Now as the name suggests, botryoid is nothing but clusters of grapes. Okay, so thus it appears as polycystic lesions on radiograph. When you see microscopically, you will see multiple compartments divided by very thin connective tissue septae. The cavity is lined by 1 to 2 cell layered non-keratinized squamous epithelium. The fourth cyst is in the odontogenic epithelial origin variety is calcifying epithelial odontogenic cyst. As the name suggests, the cystic lining has an ability to produce dental tissues or calcific tissues in the cystic lining. Now it is very rare lesion, more commonly seen in children and young adult. It is seen in the anterior part of the mandible. Clinically, it is asymptomatic. It will be discovered on radiograph by chance. It's a painless swelling. There will be cortical plate expansion and there will be displacement of the teeth. Radiographically, small lesions you will see unilocular radiolucency. In case of a larger lesion, you will see multilocular radiolucency. There will be a presence of cortical plate perforation. And within these radiolucent lesion, you will see radioopaque specks or calcific bodies are seen on the radiograph. The treatment of this is enucleation. Even if it is associated with complex compound odontome, enucleation is sufficient. But if the cyst is associated with odontogenic tumors like ameloblastoma, ameloblastic fibroma, then a wide excision of the normal margin is also required along with the cystic lesion. Let's move on to the odontogenic cyst of the odontogenic epithelial origin of inflammatory variety. In this, as I mentioned earlier, there are two, radicular cyst and residual cyst. Now we'll see the radicular cyst. Now radicular cyst, as we're all aware, there will be a slow grade of long-term chronic infection there in the tooth that will move down from the tooth to the pulp into the periapical region, resulting in granuloma formation. Eventually, there is cell proliferation. The central part of the granuloma will undergo necrosis, pus formation, and a cyst will form. Now, this could either be in the periapical region or in the lateral radicular region, because sometimes there are lateral canals are also coming out and infection can move from the lateral canal, resulting in lateral radicular cyst. Most commonly, it is the most common of all the odontogenic cysts that is seen in the maxillofacial region. More commonly, females are affected in the third and the fourth decade of life. Most common in the anterior maxillary region, then in the posterior mandibular region. Clinically, there will be presence of a swelling. Okay, initially the swelling is painless, but as it most of the time it has to get infected and eventually pain will develop. Alright, on palpation. There will always be a draining sinus and the teeth on percussion will be painful. POP will be positive on percussion. Then if it is associated with the maxillary central incisors, then you will have swelling on the labial aspect, that is the labial vestibule. If it is associated with the maxillary lateral incisors, you will have a palatal swelling. If mandibular molars are associated, then there will be a buccal swelling. So there will be a swelling, there will be expansion of the cortical plate, and there will be, you can say, displacement of the adjacent tooth. Radiographically, you will see as a radiolucent lesion, surrounded by a well sclerotic border. Now this sclerotic border will always start from the lamina dura at the apex and then widen off. Always. On aspiration, in case of uninfected cyst, you will have a straw colored or a brownish fluid along with cholesterol crystal. In case of long-standing cyst, it will have a dirty white caseous material that may have a flakes of pus. Now, if you send the specimen for pathological examination, the cyst is lined by stratified squamous epithelium up to 5 mm in thickness. Rushed and hyaline bodies or mucous cells are the classical signs of these radicular cysts, and these are the most common MCQs question asked. Now, the treatment of this is, the treatment of this is you enucleate the cyst. If there is presence of a sinus tract, you excise the sinus tract, because what happened, there is epithelial ingrowth can take place in the sinus tract and can eventually become a permanent fistula. So you need to remove the sinus tract. Then comes the non-vital tooth. If the tooth is restorable, do a root canal treatment and restore the tooth. If the tooth, and then do an episectomy along with it. If the tooth is not restorable, then you need to extract the tooth. The next is residual cyst. As the name suggests, it arises because you have left behind some remnant of granulation tissue or a part of cystic lining behind, which eventually result in cystic formation. It is very rare entity, more commonly seen in middle-aged and elderly patient, where you have done multiple extraction in a patient, and in that hurry, you've just forgotten to remove any kind of granuloma that is present at the root apice. And then this will eventually, when the patient come to you for either an RPD or a denture, or you can say a bridge, then on a radiograph you will see a residual cyst. It is more commonly seen in the mandible, that too in the edentulous span side. Clinically, it is asymptomatic. It is normally discovered on the radiograph. Treatment is enucleation. Let's move on to the intraosseous cyst of non-odontogenic epithelial origin. In this, we have developmental fissural cyst. They arise owing to epithelial entrapment in the line of closure of developmental facial processes during embryological development. The first one is median mandibular cyst. It is very rare entity. It has no sex predilection. The site is, it is present symmetrically in the midline of mandibular symphysis. It occurs because of epithelial inclusion that take place when the two sides of the mandibular processes try to unite. Now, clinically, you will have a small labial swelling will be there, present 2 to 3 mm in size. Associated teeth will be vital and there will be displacement of teeth. Radiographically, you will see a well-defined circular ovoid radiolucency. The lamina dura of the adjacent teeth will always be intact. Treatment is enucleation. Now, median palatal cyst. Now, if the cyst is present in the maxillary alveolus, then it is median alveolar cyst. And if between the incisive fossa and the posterior part of the hard palate, then it is termed as median palatal cyst. Okay, it is a painless palpable ovoid swelling in the mid-palatine region, you can see. So radiographically, you have to take an occlusal radiograph to visualize the swelling. Then you will see an ovoid irregular radiolucency in the mid-palatal region. Treatment is enucleation. Then is globularo-maxillary cyst or lateral fissural cyst. Now it arises because of epithelial inclusion between the frontonasal process or the maxillary process or globular process. Now it occurs between the maxillary lateral incisor and the cuspid teeth, that is the canine. Clinically, the lateral and the maxillary canine, they are tilted coronally and both of the tooth are vital. Radiographically, you will see a pear-shaped radiolucency. The lamina dura will be intact, but the root are divergent. That's the reason why clinically you will see that the crown are facing towards each other, that is they are convergent. Treatment is enucleation. Let's move on to the intraosseous cyst of odontogenic epithelium, that is incisive canal cyst or nasopalatine duct cyst. Now it arises because of epithelial inclusion in the incisive canal. This is the most common of all the three varieties that I have discussed. The site is, it is present at the apices of the central incisor. So clinically you will have a swelling on the labial aspect just above the apices of the maxillary central incisor. Sometimes you might have a discharge, that is draining sinus associated with it. Radiographically, you will see a heart-shaped radiolucency. And when you aspirate it, there will be viscous fluid or mucus fluid or sometimes even pus. Now, if this swelling, increase in size, it try to compress the nasopalatine nerve. So the patient may complain of burning sensation in the distribution of nasopalatine area because of the compression. Sometimes a salty discharge can also be come out from the nasopalatine area. Treatment is enucleation. Let's move on to the soft tissue cyst of the maxillofacial region. We begin with the gingival cyst. Gingival cyst could either be in adult or an infant. Now, what is the difference between the two? In gingival cyst of adult, it is seen in the canine and premolar region of the mandible, and it is associated with the attached gingiva and the interdental papillae. It is painless, slow-growing, smooth surface lesion. Overlying mucosa is normal. Adjacent teeth are vital. Okay. Whereas in case of gingival cyst of an infant, it is termed as a Bone's nodule or abstain pearl. It is seen either on the buccal or the lingual aspect of the edentulous ridge, and it has a discrete white swelling. That's why it is also called as abstain pearl. It will eventually rupture spontaneously as the underlying tooth erupt. So no treatment is required for both of the condition. Then is nasolabial cyst. It is a true fissural soft tissue cyst. There is inclusion of epithelium take place between the frontonasal prominence and globulomaxillary prominence. Now, it is more commonly seen above the buccal sulcus, okay, under the ala of the nose, at the junction of globular and the lateral nasal and the maxillary process. Okay, as you can see in the photograph, clinically, your nasolabial fold is obliterated. There will be swelling that will try to lift your base of the ala, resulting in facial asymmetry and nasal asymmetry. When you aspirate the content is straw colored or whitish mucus material. The treatment for this is enucleation. Then the second variety in this is mucocele. It is a painless, slow-growing recurrent swelling, not more than 1 centimeter in size. Okay. Now mucocele could be either retention or extravasation type. Now extravasation type can occur in the lower lip, the most common site, and it is because of trauma. Those patients that have a habit of lip biting can cause extravasation cyst. Extravasation means pooling out of saliva. So it occurs because of the saliva is pulled out from the minor salivary gland and it gets collected within a sac. That is extravasation. Whereas retention takes place at the floor of the mouth. Like because of the gravity, it is well retained in that area and surrounded by an epithelial lining. Now superficial lesion you will see as a raised circumscribed vesicle which is bluish in coloration, very thin overlining. It may rupture spontaneously and recur again and again if the cause is not eliminated. Deeper lesions are firm, well circumscribed, but the color of the overlining mucosa is normal, similar to the adjacent mucosa. Now treatment of mucocele is excision with strict removal of any projecting peripheral minor salivary glands. If it is attached to the cyst and projecting out, you need to remove them. Avoid any further injury to the nearby salivary gland duct during primary closure. If you do injury, then there is recurrence again. Now remove the offending cause, like there will either be continuous trauma or a sharp tooth that is keep on hitting at that area. So you need to trim the tooth or trim the denture and remove that cause. Then we move on to ranula. It is the term used for a mucocele that occur in the floor of the mouth associated with either sublingual or Wharton's duct. The name is derived from the word rana because the swelling resembles the underbelly of the frog. Okay. Clinically, it is a slow enlarging painless swelling, okay, on one side of the floor of the mouth. It is soft in consistency, free and mobile, it is fluctuant, non-pitting on pressure. It produces deviation and superior elevation of the tongue. So if it is very large, it may compromise the airway of the patient. So you need to remove it. Superficial ranula is translucent bluish in color, whereas deep-seated ranula is overlining mucosa is normal in appearance. Treatment is excision of the ranula. In case of a deep-seated now, excision could be intraoral approach, and if it is very deep, it could be extraoral approach. Or you could do a marsupialization in case of a large ranula, and then later on you can remove it. Removal of sublingual gland combined with the excision of ranula is a must if you want to prevent the recurrence rate. Thus with this I would like to conclude by saying that most of the time cystic lesion might have same clinical features. So you should have a differential diagnosis. At the same time, you should make the utmost use of diagnostic tools like radiograph, aspiration biopsy, histopathological examination to narrow down this differential diagnosis and come to a final diagnosis. Thank you.